Okay, now let us start with chapter 54th of your Apurba Sastry Essentials of Microbiology, which is about leprosy. In this chapter, we will be previewing clinical manifestation, immune response, complications, epidemiology, lab diagnosis, and treatment of leprosy. Introduction. Mycobacterium leprae is the causative agent of leprosy, a disease of antiquity having been recognized since long time, such as Vedic times in India, described as Kushtrog in Srushut Samhita 600 BC, Biblical times in the Middle East, Hippocrates 460 BC. The credit of discovery of lepra bacilli goes to G. H. Armor Hansen 1873 in Norway. Although M. leprae the first bacterial pathogen of humans to be described, still it remains one of the least understood organisms, probably because it is not cultivable. However, Shepherd had done a breakthrough by multiplying the lepra bacilli in the foot pads of mice kept at a low temperature at 20 degrees Celsius. Social stigma. Leprosy was once believed to be highly contagious disease due to fear, ignorance, superstitious beliefs, and characteristic deformities and disfigurement produced in the patients. Leprosy remained a social stigma over many years. Patients were considered as unclean and were socially outcasted. Today, with early diagnosis and effective treatment, patients can lead productive life in the community and the deformities can largely be prevented. Clinical manifestations. Leprosy is a chronic granulomatous disease of humans, primarily involving cooler parts of the body, skin, peripheral nerves, upper respiratory tract, eyes, and testes, etc., but are capable of affecting any tissue or organ, causing bony deformities and disfigurements in untreated cases. Incubation period. Leprosy has a long incubation period, on average of 5 to 7 years, vary between 2 and 40 years. This can be attributed to the longer generation time of lepra bacilli of 12 to 13 days as compared to 14 hours for tubercle bacillus and about 20 minutes for the coliform bacilli. Lepromatous cases have longer incubation period than tuberculoid cases. Classification of leprosy. Leprosy can be classified into various categories based on clinical, bacteriological, immunological, and histological status of the patients. There are three classification schemes. Following initiation of treatment or alteration of host immunity, the leprosy category of patient changes from one type to another type. There is another clinical classification described below. Clinical classification based on the number of skin lesions, presence of nerve involvement, and identification of bacilli on slit skin smear. Leprosy can be classified into two categories. This classification is used by Leprosy Control Program for the treatment of patients. Paucibacillary PB leprosy, a case of leprosy which fulfills all criteria: 1 to 5 skin lesions, no nerve involvement, slit skin smear negative for lepra bacilli. Multibacillary MB leprosy, a case of leprosy which fulfills any one of the criteria: more than 5 skin lesions or nerve involvement, neuritis, or slit skin smear positive for lepra bacilli. Now, the conventional classifications of leprosy. Ridley-Joplin classification 1966 classifies into lepromatous leprosy, borderline lepromatous leprosy, borderline leprosy BB, borderline tuberculoid leprosy BT, and tuberculoid leprosy TT. Madrid classification 1953 lepromatous type, borderline, intermediate type, and tuberculoid type. Indian classification 1981 lepromatous type, borderline, intermediate type, pure neuritic type, and tuberculoid type. Okay. Now the differences between lepromatous and tuberculoid leprosy. The bacillary load in lepromatous leprosy is multibacillary, while in tuberculoid is paucibacillary. Bacteriological index in lepromatous leprosy is 4 to 6 plus, while in tuberculoid leprosy is 0 to 1 plus. Skin lesions in lepromatous leprosy are many symmetrical, margin is irregular. Lesions appear as multiple nodules, lepromata, and plaques like xanthoma like papules, leonine facies, and eyebrow alopecia can also be seen. While in tuberculoid leprosy, one or few asymmetric margin is sharp. Lesion appear as hypopigmented annular macules with elevated borders, tendency towards central clearing. In lepromatous leprosy, nerve lesions appear late. Hyposthesia is late sign. Variable nerve palsies can be seen. While in tuberculoid leprosy, early anesthetic skin lesion, enlarged thickened nerves, and nerve abscesses can be seen, common in BT. CMI is low in lepromatous while normal in tuberculoid. Lepromin test is negative in lepromatous while positive in tuberculoid. Humoral immunity is exaggerated in lepromatous while normal in tuberculoid. Macrophages are foamy type lipid laden in lepromatous while epithelioid type in tuberculoid, and Langerhans giant cells are not seen in lepromatous while they are found in the tuberculoid leprosy. Leprosy is a bipolar disease under any classification scheme. Lepromatous and tuberculoid cases are the two extreme poles of the disease. Lepromatous leprosy LL. It is seen when the host resistance is low to lepra bacilli. Multivacillary disease, large number of acid-fast bacilli are found in large clumps globi inside the macrophages lepra cells. Skin lesions are many, symmetrical with irregular margin. Lesions appear as superficial nodular lesions, lepromata, or plaques, or xanthoma-like papules. Lesions on the face produce leonine facies appearance. Loss of eyebrow lashes may occur late. Nerve lesions. The nerve involvement occurs very late in LL patients. Host immunity. The CMI of the LL patient is grossly impaired. As a result, the lepromin test and lymphocyte transformation test become negative. In contrast, the humoral immune response is exaggerated in LL patients. Spread bacilli invade the nasal mucosa and are shed in large numbers in nasal secretions. LL patients are the most infectious. Later on, reticuloendothelial system, eyes, testes, kidneys, and bones are also involved. Eventually, any organ can be involved except CNS and lungs. Okay, bacteremia is common while the prognosis LL patients have a poor prognosis. In this figure, we can see the nodular lesions of lepromatous leprosy in type A, and in the figure B, we can see hypopigmented skin lesions of tuberculoid leprosy. Now coming on to tuberculosis leprosy or the TT. It is seen in patients showing high degree of resistance to lepra bacilli. Paucibacillary disease. Bacilli are scanty in the lesion. Skin lesions are few, asymmetric and sharply demarcated, consisting of hypopigmented annular macules and aesthetic patches with elevated borders. Nerve lesion. Nerve involvement occurs early. Nerves are often enlarged and thickened. Nerve abscesses may be seen, common in TT and BT. Pronounced nerve damage may lead to deformities, particularly in the hands and feet. Most common nerves involved are ulnar nerve followed by post-auricular nerve. Medial popliteal nerve is never involved. Host immunity CMI is adequate and lepromin test is positive. Humoral immune response is also normal. Least infectious TT patients are least infectious amongst all types. Prognosis TT patients have good prognosis among all types. Other categories of leprosy, borderline type, it is seen in the patients possessing characteristic between tuberculoid and lepromatous types. They may shift to either TT or LL type depending on chemotherapy or alterations in the host resistance. Intermediate type, this denotes those early unstable cases with one or two hypopigmented macules and definite sensory impairment. Lesions are bacteriologically negative. Pure neuritic type, these patients develop neural involvement without any skin lesion. Cases are bacteriologically negative. Immune response. Immune response to leprobacilli is the most important factor that determines the outcome of the infection. Innate immunity. People show a high degree of innate immunity to leprobacilli so that only a minority of those infected develop clinical disease. Cell-mediated immune response. M. leprae being obligate intracellular CMI plays a vital role in control of the disease. The category of leprosy develop is determined by CMI status of the individual. People with low CMI usually develop LL type of lesions. People with intact CMI develop TT type of lesions. Humoral immune response. Antibodies have a minor role in disease control as M. leprae is intracellular. In LL patients, there occur an exaggerated Th2 response which releases cytokines that cause polyclonal B cell activation, producing high titer of antibodies, both specific and non-specific antibodies. Complication in leprosy patients may be of two types: deformities and allergic responses, called lepra reactions. Deformities. About 25% of untreated cases develop deformities in due course of time, which may arise due to nerve injury leading to muscle weakness or paralysis, or process, facial deformities, or loss of eyebrow, or infection or injury ulcers. Common deformities include face leonine facies, sagging face, loss of eyebrow or eyelashes, saddle nose and corneal opacity, and ulcers. Hands, claw, hand, and wrist drop can be seen. In this figure, we can see the deformities in untreated lepromatous leprosy. Figure A shows saddle nose deformity. Figure B shows bony deformity, while the C shows corneal opacity. In feet, we can see the foot drop, clawing of toes, inversion of foot, and plantar ulcers. Now, the lepra reaction, though leprosy runs as a chronic uh, disease, several allergic type of acute exacerbations occur throughout this course called lepra reactions. Two types 1 and 2 described in the table. Epidemiology, source of infection, multibacillary LL and BL cases are the most important sources of infection. Asymptomatic cases can also have a role in transmission. Tuberculosis leprosy cases do not transmit infection efficiently. Mode of transmission: M. lepri has multiple routes of transmission. Portal of entry is either nose or skin. Nasal droplet infection: aerosol containing M. lepri is the most common mode. A sneeze from an untreated LL patient may contain more than 10 to the power 10 lepra bacilli. Contact transmission: skin direct contact from person to person and indirect contact with infected soil, fomites such as clothes and linens. Direct dermal inoculation during tattooing. Communicability: leprosy is not highly communicable. Intimate and prolonged contact is necessary for transmission. Only about 5% of the spouses living with the leprosy patient develop disease. The disease is more likely if contact occurs during childhood. Environmental factors that promote infection include people of rural areas, moist soil, humidity, and overcrowding. Males are affected twice commonly than females. In this table, we can see the lepra reactions. Characteristics: hypersensitivity. Lepra reaction type 1 is type 4 delayed hypersensitivity, while type 2nd lepra reaction is the type 3rd immune complex mediated hypersensitivity. Lepra reaction type 1 is seen with borderline leprosy and type 2 is seen with lepromatous variety BLLL. Type 1 manifests as inflammation of previous lesion, new skin lesion, and neuritis, while type 2 manifests as crops of painful erythematous papules which become nodular called ENL. Type 1 progresses as if occurs before treatment, progress towards LL downgrading reactions. If it occurs after treatment, progress towards TT reversal reaction. And the type 2 usually occurs following the start of chemotherapy. In type 1 T helper response, Th1 predominates, leading to more interferon gamma and IL-2, while in type 2 Th2 predominates, leads to more interleukin 6, interleukin 8. TNF alpha also plays a central role. About other organs in type 1 usually not affected, while eyes, testes, and kidney are affected in type 2. Treatment in type 1 is by glucocorticoid, while in type 2 is by glucocorticoid, thalidomide, clofazimine, and antipyretics. The type 2 lepra reaction occurs following the institution of chemotherapy. Antibiotics kill the bacilli, releasing the antigens which combine with circulating antibodies, and the immune complexes formed are deposited in skin and various parts of the body. ENL means erythema nodosum leprosum, while IFN means interferon, and IL means interleukin. Now coming on to leprosy elimination. In 1992, the WHO launched a campaign to eliminate the leprosy as a public health problem by year 2000. The goal was kept as less than one case per 10,000 population. India, with the intense effort from National Leprosy Eradication Program NLEP, India has achieved the elimination status by December 2005, although many Southeast Asian countries are yet to achieve this. Global Leprosy Strategy 2016 to 20, launched by WHO in 2016, which aims at reducing disability among children and avoiding social discrimination in all countries by 2020. Geographical distribution. Once leprosy was worldwide in distribution, but now it is almost exclusively confined to developing countries of Asia, Africa, Latin America, and Pacific world. In 2020, the world's total leprosy cases were estimated to be 127,506 with a prevalence of 0.2 per 10,000 population. India, though the disease burden has declined considerably to below elimination cutoff level, still India accounts for maximum number of leprosy cases globally. As of 2020, leprosy cases in India were 65,147, 51% of the world's leprosy cases, with a prevalence rate of 0.57 per 10,000 population. 5 states or UTs reported prevalence above elimination cutoff of more than 1 per 10,000 population as on 31st March 2018. Highest prevalence from Dadar and Nagar Haveli, followed by Chhattisgarh, Odisha, and Bihar. World Leprosy Day is observed on the last Sunday of January every year. In India, it is celebrated on 30th January. Now, coming on to lab diagnosis. Smear microscopy. Smear microscopy is done to demonstrate the acid-fast bacilli in the lesion. Specimen collection. Total 6 samples are collected. 4 from skin, forehead, cheek, skin, chin and buttock. 1 from earlobe and nasal mucosa by nasal blow or scraping. Slit skin smear is the technique followed to collect the skin and earlobe specimens. The edge of the lesion is the preferred site. Lesion is cleaned with spirit and then is pinched up tight to minimize bleeding. A 5 mm long incision is made with a scalpel deep enough to get into the infiltrated layers. After wiping off blood or lymph that may have exuded, the scalpel blade is rotated transversely to scrape the sides and the base of the incision to obtain a tissue pulp from below the epidermis, which is smeared uniformly over an area of 8 mm diameter on a slide. Nasal specimen. Nasal blow. Early morning mucus material is collected by blowing the patient's nose on a clean cellophane sheet or nasal scraping by using a mucosal scraper to scrape the nasal septum sufficiently to remove a piece of mucous membrane, which is transferred onto a slide and teased out in uniform smear. Nasal scrapings are not recommended as a routine. Biopsy from the thickened nerves and nodular lesions may be necessary in some cases. Appearance. M. leprae is less acid fast compared to tubercle bacilli. Therefore, the smears are stained by Zeal-Nansen's technique by using 5% sulfuric acid for decolorization. Under oil immersion objective, red acid fast bacilli are seen arranged singly or in groups, cigar-like bundles, bound together by lipid-like substance, the glia, to form globi. The globi are present inside the foamy macrophages called Virchow's lepra cells or foamy cells. Live bacilli will be uniformly stained with parallel sides and round ends, and length is 5 times the width. Dead bacilli are less uniformly stained and have fragmented and granular appearance. Grading of the smear. The smear are graded on the basis of number of bacilli per oil immersion field OIF as follows: 1 to 10 bacilli in 100 OIF 1 plus, 1 to 10 bacilli in 10 OIF 2 plus. Now in this figure we can see the acid fast stained slit-like smear showing numerous Mycobacterium leprae singly or in globi. The pink stained areas are M. leprae. Now continuing, 1 to 10 bacilli per oil immersion field is 3 plus, 10 to 100 bacilli per OIF is 4 plus, 100 to 1000 bacilli per OIF is 5 plus, and more than 1000 bacilli or bacilli in clumps and globi in each oil immersion film is 6 plus. Bacteriological index. It is based on the total number of bacilli live and dead seen per oil immersion field. The bacteriological index is calculated by totaling the number of pluses scored in the all smears and divided by the number of smears examined. Morphological index MI is expressed as the percentage of uniformly stained bacilli out of the total number of bacilli counted. MI is better marker to monitor the treatment response. Following clinical improvement by treatment, the MI should fall down, whereas the BI may remain the same. SFG percentage, solid fragmented granular rod percentage. Since the percentage of solid fragmented granular rods are recorded separately, this method gives better picture of bacterial morphology and is more sensitive indicator of monitoring the treatment response than MI. Now, the mouse foot pad cultivation. M. leprae is not cultivable in the artificial culture media or in the tissue culture, hence it does not follow the Koch postulates. The only certain way to cultivate M. leprae is by inoculating the specimens into the foot pad of mice and keeping at 20 degrees Celsius for 6 to 9 months. Other animals such as nine-banded armadillo, Daspus novemcinctus can also be used. Advantages: it is 10 times more sensitive than microscopy, useful in detecting drug resistance, evaluating the potency of drugs, detects viability of the bacilli. Disadvantages: time consuming 6 to 9 months and ethical issues regarding the use of animals. Now, third, antibody detection. FLA-ABS fluorescent leprosy antibody absorption test. It is widely used to identify subclinical cases. It detects M. leprae specific antibodies irrespective of duration and stage of the disease. It claims to be 92% sensitive and 100% specific. ELISA detecting IgM antibodies to PGL1 phenolic glycolipid 1 antigen of M. leprae are found in 95% of the patients with untreated LL patients, and the titrate decreases with effective therapy. However, its sensitivity is low, 60% in TD patients. Test for detecting CMI Lepromin test. Lepromin test is discovered by Mistruda 1919, demonstrates the delayed hypersensitivity reaction against the lepra antigen. It also indicates an intact host CMI. However, it is not used for diagnosis of active infection. It is useful in classifying the lesions of leprosy and also called as prognostic indicator. Now, procedure lepromin antigen injected intradermally to the forearm. Reading is taken at two occasions. At 48 hours early of Hernandez reaction, induration more than 10 mm is produced at the site of inoculation, which corresponds to TTH reaction to lepra antigen and indicates past exposure to lepra bacilli. At 21 days late or Mistruda reaction, the nodule of more than 5 mm size is formed at the site of inoculation, which subsequently ulcerates. If positive, indicates that the patient's CMI is intact, which usually occurs in TD cases and good prognosis. If negative, indicates the absence of CMI, which occurs late in LL cases and poor prognosis. Treatment: because of the risk of development of drug resistance to a single drug, WHO recommends multi-drug therapy for the treatment of leprosy. Recommended drugs: dapsone, rifampicin, and clofazimine. Alternate drugs: ethionamide, quinolones, ofloxacin, minocycline, and clarithromycin. WHO regime 2018. Three drug regime. WHO recommends a three drug regime of rifampicin, dapsone, and clofazimine for all leprosy patients. Dapsone 100 mg is given daily, self-administered. Rifampicin 600 mg is given once a month under supervision, and clofazimine 300 mg is given once a month under supervision and by 50 mg daily, self-administered. Duration of the treatment: 6 months of paucibacillary leprosy and 12 months of multibacillary leprosy. Follow-up is conducted annually for 2 years for paucibacillary leprosy and for 5 years for multibacillary leprosy. Note: earlier to 2018, clofazimine was given only for multibacillary leprosy. Many countries are yet to adopt the new WHO regime. Prevention of leprosy: active case finding and effective treatment uh, are important measure to control leprosy. BCG vaccine: there is no effective vaccine available so far. Trials were done using BCG vaccine alone or in combination with killed lepra bacilli, ICRC bacillus. MIP vaccine, a killed leprosy vaccine, has been recently developed in India in 2018 using Mycobacterium indicus prani. MIP trials have shown that if the vaccine is given to people in close contact, cases can be brought down by 60% in 3 years. Chemoprophylaxis: dapsone may be effective when given to high-risk household contacts of tuberculosis patients, but not for lepromatous patients, hence not recommended. Hospitalized patients need not be isolated as transmission requires prolonged contact. Short or lab diagnosis of leprosy and lepromatous leprosy can be written, and epidemiology and treatment of leprosy can also be answered. Okay, so this completes our chapter. Next, we'll be starting with miscellaneous bacterial infection of skin and soft tissues. Okay, for the timing, like, share, subscribe. Thanks for watching.